I wanted to thank SAGES for giving us the opportunity to present today. I'm not a doctor. I'm a med school student at the Medical College of Wisconsin. And today I'll be presenting on supply costs and early clinical outcomes comparing robotic extended totally extraperitoneal with robotic intraperitoneal online mesh for midline ventral hernias. Is it this button? Oh. These are our disclosures. So some quick background information. IPOM is an intraperitoneal only mesh that involves placing a mesh against the abdominal wall inside the peritoneal cavity. ETEP is an extended totally extraperitoneal procedure that involves placing a mesh behind the rectus abdominis muscle above the posterior sheath and peritoneum. ETEP repairs have several theoretical advantages over IPOM repairs, and these include allowing for a cheaper non-barrier coated mesh and avoiding complications for intraperitoneal mesh placement, such as adhesions, mesh erosions, and fistulas. However, one area in need of further investigation is cost and clinical comparisons following robotic ETEP and IPOM. We hypothesize that the procedural cost for robotic IPOM will exceed that of ETEP for midline ventral hernias, and that early clinical outcomes will be similar between groups. This is a retrospective matched cohort study at a single academic institution from 2019 to 2023. Patients were matched one-to-one based off of age, BMI, ASA class, hernia defect size, and whether they underwent concomitant procedures at the time of repair. So primary outcomes included supply costs, OR, anesthesia, and PACU costs. Cost data was obtained from supply cost receipts from the operating room and our billing department. Secondary outcomes included operative time, length of hospital stay, post-operative complications, 30-day readmissions, hernia recurrence, inpatient opioid utilization, and post-operative pain scores. A total of 88 patients were matched, 44 from each group. For the entire cohort, mean age was 57 and the mean BMI was 35. Hernia size was similar for both groups, with a median hernia size defect of 25 for the IPOMs compared to 40 centimeters squared for the ETEPs. Total operative time was significantly shorter for IPOMs, which was 159 minutes compared to 198 minutes. Procedural supply cost data included supplies physically accounted for during surgery and were broken down into instruments, disposable mesh, and other costs. There was no significant difference in total procedure supply costs, with a median cost of $2,338 for the IPOMs compared to $2,082 for the ETEPs, and a p-value of 0.071. Cost of disposables and other costs were the only costs that were significantly different across procedures. The greatest contributor to higher IPOM disposable costs are suture and tacker costs. Fixation devices are needed in the IPOM procedures to prevent mesh migration in the peritoneum, while ETEP procedures lack this need for retromuscular mesh placement due to intra-abdominal forces. Other costs included positioning aids, supporting garments, suction, and prep costs. Our additional cost data includes anesthesia, OR, and PACU costs. Total anesthesia costs were significantly higher for IPOMs with a p-value of 0.045. Anesthesia costs are broken down into labor and drug costs. Anesthesia labor costs encompasses perioperative labor for anesthesia providers, while drug costs are a sum total of all the medications used by the anesthesia providers during the pre-op, intra-op, and post-op phases. There were no significant differences in the total OR costs. OR supply costs encompasses both direct and indirect costs regarding the operating theater, the robotic system, OR disposables, and OR non-disposables. The total inpatient MME utilized was significantly higher for the IPOMs. It was 61 compared to 29 MME. This is corroborated with statistically higher mean postoperative pain scores for the IPOM group on day 0. And the average length of stay was half a day longer for the IPOMs. Other clinical outcomes, including postoperative complications, 30-day readmissions, and hernia recurrence rate, were not significantly different. As for our limitations, cohorts were not equally distributed across surgeons. We were unable to mitigate selection bias for case complexity despite our best efforts to match our patients. And cost comparisons are especially challenging to compare with how procedure costs, labor, and medical supply costs vary significantly across geographical locations and hospital systems. We concluded that there is no difference in procedure supply costs, OR or PACU costs between patients undergoing either procedure. Though this study did find statistically significant differences in total inpatient MME and length of stay, it is debatable whether these are clinically significant, and more study is needed to determine appropriate indications for and benefits of robotic ETEP over IPOM. Thank you very much. Any questions?